Welcome to the Clinical Liver Disease video series. Clinical Liver Disease is an official digital learning publication of the ASLD. I am Joshua Lee, a GI fellow at Duke University Medical Center, and the author of Getting to the Core of the Matter, the Importance of Biopsy in an Unusual Case of Acute Liver Failure. Acute liver failure is a clinical syndrome which presents as acute liver injury, coagulopathy, and encephalopathy within 26 weeks of symptom onset in patients with no prior liver disease. As liver injury progresses, cytokines are released from injured hepatocytes and surrounding cells, leading to cardiovascular collapse, metabolic derangements, and multi-organ failure. This common pathway can be caused by multiple different etiologies. Unfortunately, outside of supportive care, correction of electrolyte abnormalities, and liver transplantation, there are few therapies for acute liver failure, especially if an etiology cannot be determined. Within the United States, acetaminophen and idiosyncratic drug reactions are the most common causes of acute liver failure, followed by viral hepatitis, ischemia, and autoimmune hepatitis. When the cause is not evident, however, more uncommon etiologies must be considered. In this article, we present a case of acute liver failure in a previously healthy 79-year-old woman. She originally presented with multiple weeks of generalized weakness and diarrhea in the context of recent upper respiratory symptoms. On presentation, she was hyponatremic to 110 and had acute kidney injury. Her transaminases showed an initial AST of 975, ALT of 326, alkaline phosphatase of 1269, bilirubin of 8.6, and INR of 1.6. Notably, her LFTs were normal 3 months prior. Due to her findings, she was transferred to a tertiary referral hospital on hospital day 2. On initial examination, she was jaundiced and had no stigmata of chronic liver disease. Her abdomen was non-distended and non-tender, and she had no hepatosplenomegaly. Her mental status was normal, without signs of asterixis. Infectious workup was negative for acute viral hepatitis, herpes simplex, and varicella zoster, and Epstein-Barr virus infection. Cytomegalovirus DNA was detected but unmeasurable. Anti-nuclear antibody, anti-smooth muscle antibody, immunoglobulin G levels were normal. Finally, ultrasound of her liver with Doppler was negative for any structural or parenchymal abnormalities, and an echocardiogram demonstrated a normal ejection fraction with a moderate pericardial effusion. Due to the uncertainty of her diagnosis, she underwent ultrasound-guided liver biopsy. This showed areas of hepatocyte necrosis admixed with cells with variable amounts of cytoplasm. Through immunohistochemical staining, these cells were found to be of T-cell origin but lacked many other T-cell antigens. This was further characterized as peripheral T-cell lymphoma not otherwise specified. Unfortunately, shortly after the diagnosis, she developed worsening coagulopathy, metabolic derangements, and hepatic encephalopathy. After goals of care discussions with family, she was transitioned to comfort care. Malignant infiltration is a rare cause of acute liver failure despite being a common site for metastatic disease. Overall, malignant infiltration accounts for around 1% of causes of acute liver failure. Leukemia and lymphoma are the most common cause at 44%, followed by breast and colon. Peripheral T-cell lymphoma often presents with nodal disease, with extranodal disease alone comprising only 13% of cases. Extranodal sites often involve the spleen, liver, and skin. The prognosis is poor even with treatment, with a 32% 5-year survival rate. This case highlights the importance of maintaining a broad differential in the workup of acute liver failure and ensuring that liver biopsy is considered early when the etiology is not identified based upon history, serologic, and radiographic workup. Malignant infiltration is a contraindication of liver transplantation and would not have otherwise been identified if biopsy was not pursued in this case. On behalf of all of us in the clinical liver disease team, I hope you found this video useful. For more information about acute liver failure, please visit us at www.cldlearning.com. Thank you for watching.